Hello students, I am Dr. Jansiya, Assistant Professor from the Department of Orthodontics and Dentofacial Orthopedics, Vinaya Mission, Sangracharya Dental College, Salem. Students, today I am going to discuss with you, the topic is Interceptive Orthodontics. You know very well in orthodontics there are branches are there. There are corrective, preventive and interceptive. This is very important for the orthodontist to achieve a ideal occlusion. So today we are going to study about the interceptive orthodontics. So the early interceptive orthodontics is an approach that can be extremely effective for children. Coming to introduction, interceptive orthodontics is undertaken at a time when the malocclusion has already developed or is developing. So interceptive orthodontics basically refers to measures undertaken to prevent a potential malocclusion from progressing into a more severe one. There are certain definitions are given. According to American Association of Orthodontics in the year 1969 defined interceptive orthodontics as the phase of science and art of orthodontics employed to recognize and eliminate the potential irregularities and malposition in the developing dentofacial complex. The other definition is given by Profit and Ackerman in the year 1980. Defined interceptive orthodontics as the elimination of existing interferences with the key factors involved in the development of the dentition. There are some basic interceptive procedures that are undertaken in the interceptive orthodontics. There are serial extraction, correction of developing crossbite, control of abnormal habits, space regaining, muscle exercise, interception of skeletal marrelation, removal of soft tissue or bony barrier to enable eruption of teeth. Students, now we are going to see about the space regaining. What do you mean by space regaining? Suppose if a primary molar is lost early and space maintainer is not used, what will happen is a reduction in the arch length. Here there is space is there, no? So if there is any reduction in the arch length by mesial movement of the first molar can be expected. In such patient, the space lost by the mesial movement of molar can be regained by distal movement of the first molar. So the space regaining procedures are preferably undertaken at the early age prior to the eruption of the second molar. There are types of space regainer. There are two types, fixed appliances and removable appliances. In fixed appliances, there are Gerber space regainer that is mostly commonly used, an open coil or herb space regainer, jack screw space regainer. In removable appliance, we have Hollis appliance with helical spring, split acrylic dumbbell spring with slingshot elastics, palatal spring and expansion screws. Coming to correction of developing crossbite. Crossbite, it can be anterior or posterior, should be corrected as soon as they are detected. It may be better to treat them as the permanent teeth begin to erupt into the oral cavity. So the child may be too young and uncooperative at deciduous dentition stage. So crossbite can be unilateral or bilateral. These can occur also be true or functional in nature or combination of the two. So there are anterior crossbites can be broadly classified as dentoalveolar anterior crossbite, skeletal anterior crossbite and functional anterior crossbite. So students, in mixed dentition period as well as deciduous dentition, due to some root causes, it may be or any ENT problem like breathing problem, kids have a tend to develop a pseudo class 3 malocclusion. So in that time, we need to identify that type of malocclusion to correct by giving some appliances to correct the malocclusions. So this is very important in the correction of developing crossbite, that is called interceptive orthodontics. And there are some habits also is most frequently practiced by the children and is capable of producing damaging effects on the dentoalveolar structures. So there are mainly by thumb sucking and also tongue thrusting, mouth breathing, lip sucking or biting also create the malocclusions. For example, in this picture you can see that midline diastema has developed due to thumb sucking, and what will happen is there will be anti-clockwise growth of the maxillary segment will happen. So these are the effects will be there when the kids have some habits. So we can give some muscle exercise in case of kids having a hypotonic lips. So the normal development of the occlusion depends on nature of the muscles of the face. muscle exercise allow a clinician to bring such aberrant muscular functions into normal functioning. Uses to guide the development of the occlusion, to allow the optimal growth patterns, to provide retention and stability in post-operative mechanical orthodontic cases. So there are some exercises we can give in the mixed and deciduous dentition period. There are exercise of masseter muscles, exercise for the lips, in circumoral muscles, exercise for the tongue. Coming to serial extraction, according to Tweed, he defined as the planned and sequential removal of primary and permanent teeth to intercept and reduce the dental crowding problem. So dental crowding exists when there is an excess of tooth material in relation to amount of basal and alveolar bone that supports the teeth. So there are some procedures we are commonly accepted are Tweed's method, Dewey's method and Nance method. The Nance method is very similar to the Tweed's method. Now we are going to see about the indications, which are the cases we can do the serial extraction. In case of class 1 malocclusion with an arch size, tooth size deficiency of 5 mm or more per quadrant. Normal eruption sequence as assessed radiographically and skeletal growth pattern should be in the normal limits. The second one is if there is any arch line deficiency, which could be unilateral or bilateral, is indicated. So coming to non-pathological side, if there is any midline shift of mandibular incisor due to a displaced lateral incisor, or a premature loss of deciduous canine or abnormal canine root resorption or canine being blocked out labially. In these cases, we are expected to do the serial extractions. Coming to pathological side, if there is any extensive proximal caries and subsequent mesial migration of the teeth distal to the caries lesion, or any premature loss of deciduous teeth and lack of subsequent space maintenance, or any deleterious oral habits like thumb sucking, tongue thrusting, mouth breathing, lip biting, or any improper proximal restorations or any tooth ankylosis. In these cases, in both non-pathological and pathological, it's advised to do the serial extraction to achieve a favorable position of the permanent dentition. In which of the cases we should not do serial extractions are, it's very contraindicated in which of the cases means a mild to moderate crowding, a tooth size arch length deficiency is less than 5 mm per quadrant, or in case of class 2 division 2 or in case of class 3 malocclusion or spaced dentition or congenitally absent anodontia or oligodontia. In these cases, it's very contraindicated for the serial extractions. So what are the methods we can do serial extraction is, in this method, now we are going to see the Tweed's method. In this picture you can see that the extraction of the deciduous first molar be extracted for the reason of premolar to come into the favorable position. In step 2, extraction of the deciduous canine and first premolar to allow the premolar in coming into the favorable position. In Dewey's method of serial extraction, in this picture you can see that extraction of deciduous canine to create space for the alignment of the incisors. So if there is any crowding is there, it's advisable to remove the deciduous canine to relieve the crowding in the anterior region. In step 2, the extraction of deciduous first molar to accelerate eruption of first premolar. In step 3, in extraction of erupting first premolar to permit the permanent canine to erupt. In this case, achieve the ideal occlusion for the serial extraction to be completed. So what are the advantages in the serial extraction? First one is the more physiological treatment as teeth are guided into normal position using physiological forces, and duration of fixed treatment is reduced like fixed appliances. The health of investing tissue is preserved. Lesser retention period is required and results are more stable. There are disadvantages in serial extraction are a good clinical judgment is very important. No single approach can be universally applied. A treatment time is prolonged over 2 to 3 years. Patient cooperation is very important and tendency to develop tongue thrust as extraction space close gradually. Extraction of buccal teeth cause a deepening of the bite. These are some of the disadvantages when we do the serial extractions. So coming to interception of skeletal marrelations, if there is any skeletal problems, so how we want to correct in interceptive orthodontics. So any developing skeletal malocclusion, if detected in the earliest stage, can be intercepted to decrease in severity and times even resulting in normal occlusion. So the changes are brought by giving myofunctional appliances. So according to Mills in 1991 has defined as functional appliance as a removable or fixed appliance which changes the position of mandible so as to transmit force generated by the stretching of the muscles, fascia and periodontium through the acrylic and wire work to the dentition and achieving underlying cater structures. In very simple words, we can tell that if the kid having any class 2 convex profile, so we need to give the myofunctional appliance to bring the orthognathic profile. So in interceptive, if there are any skeletal problems, in interceptive orthodontics we need to give myofunctional appliance to achieve the orthognathic profile of the patient. If the patient having class 2 malocclusion, for example, a class 2 malocclusion generally occurs as a result of either increased maxillary growth or decreased mandibular growth or combination of the same. So in this case, we can give face bow or face mask along with the headgear, retract the excessive growth of the maxilla, whereas functional appliance bring about anterior position of the mandible to correct the class 2 malocclusions in skeletal. In the case of interception of class 3 malocclusion, class 3 malocclusion generally results due to deficiency in the maxillary growth or excessive mandibular growth or combination of the same. In the class 3 malocclusion, we can give myofunctional appliance like Frankel's 3 appliance used for the promoting growth of the deficient maxilla, and a chin compass generally used to restrict mandibular and bring the clockwise growth of the mandible. So these are the certain appliances or advice to give for the patients to achieve a orthognathic profile of the patient. The last one is removal of soft tissue and bony barriers. In some cases, usually canine is impacted. So we need to do a surgical procedure like incision of the soft tissue, the gums, and removal of the bones on the overlying of the crown of the unerupted teeth. And doing fixed appliance, we need to bring the canine into the alignment. For this purpose, we need to do the removal of soft tissue and bony barriers in the interceptive orthodontics. So I am concluding that the interceptive and preventive orthodontic procedures enable the clinician to treat and make a developing malocclusion less severe so as to allow the corrective orthodontist to deliver more stable and more conservative and non-extraction line of treatment for benefit for the patient. So thank you so much students watching my video.